Good morning, everyone. Hope you all can see this screen. First of all, I would like to thank you, CCPSL, for giving me this opportunity. So, in the next hour or so, I'm going to do a discussion and a critical appraisal of the journal article. So, the journal article we have chosen is Variations in Lipid Profile During the Critical Illness. So, a little bit about the journal article. So, a little bit about the journal. The title of the journal is Pakistan Armed Forces Medical Journal. It's indexed in Scopus and it's an international article which is peer reviewed, and it has a H index of 3 and an impact score of 0.07. Though this impact score is low, we chose this article because it's interesting and it's applicable for all the stations. So the critical evaluation will be done according to the SROBI guideline. So before discussing about the journal article, I would like to give a brief overview about lipoproteins and their reference ranges. As you all know, lipoproteins are classified on the basis of their densities into microns, VLDL, IDL, LDL, and HDL. So regarding the reference concentrations, initially at birth, plasma cholesterol concentration is low, around 66 milligrams per deciliter, which is equally distributed among LDL and HDL with very low VLDL. And triglyceride levels is about 36 milligrams per deciliter. And in cord blood, apolipoprotein A1, apolipoprotein B100, and lipoprotein B2A is about 80, 33, and 4 milligrams per deciliter respectively. And sorry for the disturbance. And there's a drastic rise in the first few months of life. And after that, LDL becomes the predominant carrier for plasma cholesterol and remains static until puberty. So after puberty, triglyceride levels, LDL cholesterol, and ApoB100 all increase in both sexes. But HDL cholesterol and ApoA1 is strongly influenced by the androgen levels, and therefore it's lower in men. After puberty, lipid levels continues to increase in both female and males, and total and LDL cholesterol and ApoB being higher in men than in women up to age 55. After 55, that means after the menopause, women have higher total and LDL cholesterol and ApoB levels than men. So we will be moving on to discuss our journal article. First of all, I would like to talk about the title. The title is Variations in Lipid Profile During Critical Illness. So if I am to critically analyze the title, it includes the research questions, it includes the aims and objectives of the study, but does it say anything about the study design? It doesn't imply us about the population and the setting which this study was done in. I think it's better if those things were also included in the title. Moving on to abstract. Sorry for the crowded slide, but I hope you all can appreciate that the abstract is here. It consists of objective, study design, and the study setting is given, methodology, results, conclusion, keywords. It's a complete abstract. So if we critically look at that, it's very informative and it provides a balanced summary of what was done and what was found. And it includes the objective study design, pace and duration of the study, methodology, results, and conclusions. So if we critically look at the keywords as well, it includes the words from the title and the commonly used words in the study, and the article search was easy. And in my opinion, I think it's better if the word lipid profile was also included in the keywords. So we are going to discuss about the introduction. I'm sure you all have read the article beforehand, but I would like to read out some specific key points in the introduction to refresh your memory. So the lipid profile repeatedly varies from start of critical illness till the time of recovery. And they have also stated that increase in triglyceride levels could be due to the hydrolysis of phospholipids to fatty acids. And high levels of triglycerides can intensify organ dysfunction, especially pancreas, and also the pulmonary and hepatic dysfunction can occur. So critically ill patients suffer from dyslipidemia and hyperglycemia, mainly because of increased hepatic lipogenesis and the gluconeogenesis. The changes in lipids have been attributed to hormones affecting fat utilization during the critical illness, including insulin, adrenaline, noradrenaline, corticotrophin, glucocorticoid, growth hormone, and thyroid hormone. Those are the main key points in the introduction, and then they have rationalized their study. Uh, they have they are telling that the magnitude of dyslipidemia is directly proportional to the inflammation. Still, a consensus has not been achieved regarding the change in triglycerides. Some studies, according to their literature review, some studies have shown that triglycerides remain unchanged with change only in the HDL cholesterol and total cholesterol levels. And according to them, there's a controversy regarding VLDL levels as well. And according to some studies, its levels in triglyceride levels increases due to increased hepatic synthesis and as compensation for decreased HDL cholesterol and phospholipids. And also, lipid profile is often advised in critically ill patients to diagnose or monitor diseases related to atherosclerosis. However, lipid tests can be misleading in such patients due to the above mentioned factors. Proper guidelines must be formulated to carry out lipid tests in such patients. So those are the rational arguments they are providing to rationalize their study. So if we critically analyze the introduction, it explains the scientific background and explain the rationale for the study and explain the purpose of the study. And the citations are followed with correct references as well, but it does not provide a pre-specified hypothesis. Normally, when you're doing a study, you should first give a hypothesis. So it's not provided here. Moving on to methodology. So here there's a brief overview, summary of the methodology they have provided. The study design is cross-sectional. Setting includes 4 military hospitals, and they have taken the samples from ICU, HDU, and CCU. They have not specified these abbreviations. We assume it's the intensive care unit, high dependency unit, and the coronary care unit. And the duration of the study is 6 months from March to September 2016. So regarding the participants, they have given specific inclusion and exclusion criteria. So according to the inclusion criteria, patients admitted in intensive care units for coronary disease, sepsis, burns, and cancer were included in the study, and their age was ranging from 18 to 75 years. And the exclusion criteria are patients on lipid-lowering drugs and the post-surgery patients. So variables they are going to assess is gender, age, and diseases. They have divided them into subgroups saying renal, CNS, CVS, sepsis, and oncology. And the sample size is 50. The statistical methods they have used is mean, SD, one-way ANOVA test, and post-hoc test for intergroup comparison. So basically, if I to summarize what they have done is that they have collected fasting blood specimens in gel tubes at admission, and after 18 hours after and 42 hours after admission from the patients in ICU, HDU, and CCU. And these specimens were centrifuged within 45 minutes in the hospital lab. And total cholesterol, triglyceride, HDL cholesterol, and LDL cholesterol levels were analyzed using a fully automated analyzer. And they have not specified the method. And they have also mentioned that LDL cholesterol was done by a kit method. That also they have not specified what's the method. And according to them, results were verified by a pathologist. Then the data was entered into a statistical package for portions and SPSS version 23. And the qualitative variables like gender, age, diseases were categorized in renal, CNS, serious, sepsis, and oncology disorders and were measured as frequency and percentages. Here they have mentioned gender, age, diseases as qualitative variables. Quantitative variables, in quantitative variables, they have mean and SD were estimated, and they have used one-way ANOVA test for the comparison of these categories, and for intergroup comparison, post-hoc test was. So, if we critically analyze the methodology they have provided, the plus points are it explains the study settings, they specify inclusion and exclusion criteria, but the methodology does not specify acute illness, whether the sample was taken at the onset of the illness, as these patients, most patients are from intensive care units. They might have been in wards beforehand, and after worsening only they will be transferred into ICUs. So the time duration, when was the sample was taken, is not specified here. It's better if it was also mentioned. Does not clarify study design, descriptive or analytical. That means they have only clarified that the study design is cross-sectional. Cross-sectional studies can be descriptive or analytical. They have not specified it. According to given data, we can assume that it's an analytical study. And they had mentioned age, gender, and diseases as qualitative variables. They are not qualitative variables, they are categorical variables where they can be divided into categories, for example, gender, male and female, and we can get a numerical value for them. So they are not qualitative variables, they are categorical variables. And it does not define exposures, potential confounders, and effect modifiers. Like example for diet, physical activity, EMI, stress, drugs. They can also affect the outcome of this trial, but they have not defined how they have minimized these exposures of confounders. Confounders means variables, as in the previous journal also it was clarified, confounders are variables which can affect both dependent and the independent variables. So they should be minimized as much as possible to get the association between the direct and indirect variable. And it also does not describe any efforts to address the potential bias, and does not explain how the sample size was calculated. And also they don't define the diagnostic criteria for subgroups, because these subgroups are very vast, like CNS diseases. There are a range of diseases which will belong in under that umbrella. So the patients, it's better if they could specify which diseases were included and how they came into that consensus. So those information was not provided in the methodology. So moving on to results. So if I am to provide a description of the study population, there were total 50 patients which were included in the study, and the patient was categorized based on the diagnosis into different disease groups. CNS 30%, sepsis and inflammatory diseases 30%, cardiovascular diseases 22%, cancer patients 10%, renal diseases 8%. Mind you that these disease groups, they don't have equal distributions. There are more patients from CNS and sepsis category and less patients from renal category. That could also affect the outcome of this study. In addition, they have told that subjects were categorized based on 5 different age groups, from 22 to 33 years. Likewise, it is not according to the age groups also, the subjects are not equally distributed. And there were 40% of female patients and 30% of male patients included in this study. So they have given a summarized version of their study results, and in each category they have tested these patient samples for triglyceride levels, total cholesterol level, HDL level, and LDL levels. And here in this column, we have their mean and SD for their lipid levels in the admission in this column after 18 hours and this column after 42 hours, and the p-value is given there. So for it to become significant, this p-value should be less than 0.05. So as you can see, most of these findings are not significant. And they have another summarized version of the values which were significant is provided here. So, according to their results, there has been a significant variations in the triglyceride levels at the time of admission, 18 hours and 42 hours, which was less than P level was less than 0.05. Whereas for total cholesterol and LDL cholesterol, HDL cholesterol and HDL cholesterol, it was not significant. As you all can appreciate in this graph table, the total cholesterol levels has also been here. It's 3.6, 3.4, and 3.2. There is a decrease, but according to their statistical analysis, it's not significant. So, if we do a critical analysis of the provided results, the data presented in tabulated form and titled properly, and it's easily comprehensible, but there is no proper description of the study participants like social, clinical. The description is lacking, and the confounders were not adjusted. Data analysis not done for variables such as age and sex. They have previously stated that they have divided the patient groups into 5 categories according to the age, but they have not provided the outcome of this analysis. And the intergroup comparison with the CNS versus CVS. Likewise, they have not provided the intergroup comparison. Though they have claimed they have done it, they have not provided it in the result. And they have stated that they have done the ANOVA test. So ANOVA test, one-way ANOVA test was performed. There is a specific value to imply the significance. Apart from p-value, there is a value called s-value that should be also provided. So those are the drawbacks in the results. So we'll move on to discussion. The discussion, they are giving the key results. The key result is there is significant variation in the triglyceride level from the time of admission, 18 hours and 42 hours. But for the whereas total cholesterol, LDL cholesterol, and HDL cholesterol, the change is not statistically significant. And they have also discussed about the limitations that they have not assessed the individual meal choices before sample collection and not assessed sample collection. And the sample size was very small. And inflammatory markers like CRP and ESR could have been done in this study to see the association. And I am going to highlight the key points they have provided in the discussion. They have stated that there is a significant increase in triglycerides attributable to the ongoing inflammatory process, peptide synthesis and lipolysis at the time. Decreased LDL cholesterol levels is consistent with the literature. These results are thought to be due to changes in cholesterol metabolism and liver regulation induced by the acute phase response. And if you look at the discussion critically, it highlights the key results and it describes the limitations, and it discuss other studies which both support and contradict the findings. They are discussed there. Those are the plus points. But according to my opinion, they should elaborate more on the implications of the study. What are the benefits they got from the study? Were they able to, they have previously in the introduction, they talked about formulating guidelines. Were they able to do that? They have not specified. And they should also discuss how to improve the study. And, these are my references. So, if time permits, I would like to. Sorry. Are there any questions?
Hello.
Yes.
Thank you. Majita here.
Yes, madam.
I just went off in between the lecture, the presentation. Is it the fasting sample you talk about this?
Madam, they have stated that they have taken the fasting samples, but they have not specified how long the fasting was it 10 hours, 12 hours, 14 hours. They have not specified that, but they are saying that it's
on admission patient is fasting.
on admission.
No, the admission. After that, you have put 12 hours and 18 hours, like that is a fasting period.
Yes, that's what they have told, madam. It might be
12 hours mean 12 hour fasting from the admission.
Madam, they have not specified how long the patient has been fasting, madam. They have
And the
just
sample took at that time.
yes, on admission, madam.
After 12 hours of admission.
But madam, this is after the admission to ICU and CCU. Maybe the patient was treated previously in the wards, madam. They have not specifically mentioned those parts. Those are lacking. Those are drawbacks of these studies.
So the time you mention is the 12 hours and 18 hours from the admission time, no?
12 hours, 18 hours and 42 hours, madam.
42 hours from the admission time, no?
Yes, madam, from the admission time.
So they didn't mention during that time the patient is fasting or not?
Madam, in the sample collection, they have said that it's a fasting sample.
Okay.
Yes.
And another thing, the LDL is calculated one or directly measured one?
Madam, they have not specified. According to this, here, madam, in the methodology, madam, they have said they have used this Siemens fully automated analyzer for LDL cholesterol measurement,
Then
madam.
it is
And
a
they
direct one, no?
yes,
They analyzed, they have said it is analyzed, no? They were analyzed.
yes, madam. So it should be not.
So then it's a direct one.
Possible.
Okay, thank you.
Thank you.
Hello, good morning, Dinithi. I have a small question. Before that, thank you for the nice presentation. What do you think about biases of this study? Can you describe on that?
Biases, as in any other study, there can be selection bias because these patients were chosen from the ICU settings. So the ideally says age, BMI, diet, those things should be analyzed, and patient should be chosen accordingly. But it has not happened here. So there is a selection bias also, and there can be as in any other study, there can be an informative bias also, because we don't know whether they don't provide us details whether the staff was trained staff was there, and whether how long the fasting has been done. They don't specify anything here, so there is an information bias as well. So as this study was only done in military hospitals, maybe the patient patient must be military person, so they are more fit than others. Likewise, there is external validity of this sample collection is also not less actually. We can't generalize the results to the normal population as I think. If Sir is there, I think he can elaborate more on these questions.
Okay, thank you, Dinithi.
I think he.
Dinithi, thank you for your excellent presentation. I have one question regarding confounders. How they have removed confounders? You have mentioned few variables.
Yes, they have not mentioned how they have mentioned about minimizing the confounders. That's a drawback of this study. Ideally, to minimize the confounders, we should first identify the confounders in this case. In this case, age, sex, diet, BMI, everything can confound the study. So ideally, we can divide the sample into two populations, two samples, and where the every confounder should be equally divided. Like if there should be 5 females from each sample and 5 females from the other category as well. Like a case control study, there should be if there are 5 vegetarians in another group, the other group there should be 5 vegetarians. Likewise, everything should be divided equally. Then the confounding effect can be minimized, like a case control study. Likewise, and in analysis also, after without doing this case control like study, we can collect the samples, and there are statistical methods like multivariant analysis where this sophisticated analysis can be done to minimize this confounding effect, but it cannot be minimized to 0, but we can minimize it to some extent. So those are the drawbacks of this study that was not done. Don't know whether they have done, but they have not mentioned these things were done in the study.
Okay, Dinithi, thank you.
Hello.
Dinithi.
Hello, Dr. Dinithi.
Yes.
Hello. Yeah, thank
Yes,
you for your
thank you.
nice comprehensive presentation. Actually, I have very simple concern. Most of the drawbacks that you have highlighted in your presentation, but I would like to know, is there any further improvements that you would like to suggest for this study?
Especially, we can increase the sample size. This study only includes 50 patients. We can increase the sample size, and then we can do a multi-center study. Here the setting is confined to military hospitals. We can do incorporate patients from different hospitals with different diseases. So it will increase the generalizability of this the findings, and as they have also suggested, like for limitations, they have mentioned that they didn't check the association with inflammatory markers like CRP and ESR. That would actually improve this study if we can check the correlation with the inflammatory markers. And also, as previously I explained, the confounding factors, the confounders should be minimized as much as possible. Those are the things I can think of.
Thank you.
Dinithi.
Yes.
Yeah, this one I normally what is the purpose of this study? They have done it for to identify the time period when we have to do the lipid profile in acute setup, or
basically like that, madam. They have in the when they were in the introduction, when they were rationalizing the study, but they have told this mainly they wanted to appreciate the changes in triglyceride levels, madam. Normally, there many studies have been done on LDL cholesterol and total cholesterol levels, but the studies that have been done regarding triglyceride levels, according to them, they are very controversial. That's why they have mainly done the study to assess the change in triglyceride levels in acute illnesses, madam, and also in the LDL, total and LDL, the other fractions as well. The but main purpose they have rationalized is to assess the triglyceride levels.
But they didn't mention which time interval is better. Is not.
No, madam. In the discussion, they have not specified, madam.
We just found that there is a significant change. That's all.
Yes, madam. In the triglyceride levels, in the LDL and the total cholesterol levels, there is a
Yes, no.
decrease, madam, but it's not statistically
Statistically
significant.
significant.
Yes, madam.
So why I asked this question is I just want to, because we are not recommending during the MI, post-MI
Yes, madam.
patients, no, the lipid profile. We are not recommending to ask for at least for 3 months. So I thought whether there is any conclusion on this, whether we can do after this time and those. They didn't mention it like that, no?
No, madam. But madam, when looking about the when I was making this presentation, they have also reference that there is a study called Luna trial on
Yeah.
yes, madam. That provides a good account than this one, madam. Actually,
Okay.
they recommend. I can't remember properly. About 1 month. After 1 month, it's better
Okay.
to not to do the lipid profile till 1 month after acute illness.
Okay. Okay. Thank you.
Dinithi, Udara here. Thank you for your excellent critical review on the article. And it's great that you observed that the statistical analysis was defective and the S value was not mentioned here. I think the main reason is because the sample size was, as you correctly mentioned, that sample size was quite low. For none of the subgroups in this study seems to be having more than 15 numbers per day. As I remember, none of them had more than 15. So probably that is the reason why they did not mention the S value, which provides the how fitted the values are with their described model. So in the case of how you would suggest improvement to the study, since they are looking at the critical the changes in triglyceride and lipid profile during critical illness. Any other suggestions you have for this improvement other than increasing the sample number?
Thank you very much, Dr. Dara, for your valuable input. That might be the reason, actually, probably.
Yeah,
And
exactly.
yes,
Any other suggestions?
I think if we can do a
I agree.
example, and
Yeah.
also if we can do a multi-center study, including more patients from each category,
Any other
the
suggestions?
generalizability would be higher.
Yes, yes. Other than multi-center study and increasing the sample number, do you have any other suggestions? Considering that it is they are looking at the lipid profile during critical illness.
In my opinion, I'm not sure whether it's better
Yeah,
or
probably.
not.
Yeah, probably. Probably we.
Yes.
Yeah, probably they could have done a longitudinal study on the same patient cohort rather than categorizing them to small groups like 4s and 3s, and like there were like 3 patients in one subcategory, wasn't there? So longitudinal study on the same patient group once they have recovered from the critical illness, so that they can actually do a nice comparison between how what was the change during the critical illness and how it changes over the time period, and if they did it at regular did the lipid profile at regular periods, then they can understand how it longitudinally changes and give better results and better advice for the readership regarding when to do, when Majida madam asked the question about like when to do the, whether there was some recommendation when to do the lipid profile after a critical illness like that, they could have given better answers for that kind of questions if they did a longitudinal study on the same patient cohort. Yes, thank you. That was my comment.
Yes. Thank you.
Udara,
Thank you very much.
Yes.
In your suggestion also that I just also want to put one comment from my side. If the different the patient's acute illness recovery is different patient to patient, no? So
Yeah,
sometimes
exactly.
1 or 2 days one person, otherwise some people are after 1 month ICU care, and so whether we can compare that that duration is different. So the recovery period we can't take it as the same, no? The patients
Yeah,
the
that
lipid
we
profile.
can't. We
Yeah.
can't, but they could have done it a longitudinal study on the same patient cohort.
So one
or
patient
like,
we can continue
yeah,
and see
one patient. Yeah, the longitudinal study, and then looked at it rather than comparing
between the patient, no?
between patients. Like if they could have done it better if they had more number of patients. That's why it's actually tricky that they did not mention the S value. That is because it was not significant. They that is deceiving the readership actually.
Okay.
Thank you, Anna.
Thank you.
Thank you, Dinithi.
Thank you. Thank you very much for your input. Who helped me